Good evening, afternoon, and morning. Welcome to our Prince Mahidan Award Conference webinar. I'm Dr. Tim Mastro, Chief Science Officer at FHI 360, based in Durham, North Carolina, USA. I have the privilege of working with the PMAC International Organizing Committee to organize this webinar on assuring equitable access to COVID vaccines, treatments, and health resources, part of the theme on what we should do for the future. The COVID-19 pandemic has provided a stark window into how social and economic inequities result in disproportionate risk and impact of novel diseases. The chronic lack of access to basic health care prior to a pandemic results in populations more likely to be living with pre-existing conditions that make them more vulnerable to the most serious consequences of a novel infectious disease. This lack of effective health services in marginalized communities further increases their risks of negative outcomes during the pandemic. Economic inequities also profoundly reduce timely access to diagnostics and life-saving medicines, in other words, vaccines and therapies. Once they become available, this dynamic is particularly evident between resource-rich and poor countries when it comes to accessing life-saving products that are in high demand when supplies are limited, including vaccines and therapeutics and personal protective equipment. These inequities underscore the importance of universal health coverage in developing a uniformly healthy population before a pandemic and mechanisms being in place for equitable provision of vaccines, therapies, and PPE during a pandemic. Moreover, vulnerable populations will be impacted by pandemic-induced impacts on education and nutrition programs. Today's webinar will explore key elements of these critical dynamics. It's my honor and pleasure to introduce our moderator for today's session, Professor Helen Rees. Professor Rees is one of South Africa's best respected clinician scientists and is internationally renowned for her research and policy work on HIV vaccines, reproductive health, and drug regulation. She is founder and executive director of the WITS Reproductive Health and HIV Institute at the University of Witwatersrand in Johannesburg, South Africa. Helen is an honorary professor in the Faculty of Infectious and Tropical Diseases at the London School of Hygiene and Tropical Diseases, and honorary fellow at the Murray Edward College at Cambridge University in the UK. Helen serves on several key committees and boards, including the South African Health Products Regulatory Authority Board, South Africa's National Advisory Group on Immunization, and the World Health Organization's Strategic Advisory Group of Experts on Immunization, and also the Global Alliance for Vaccines and Immunizations, Gavi, and the Coalition for Epidemic Preparedness, CEPI's Scientific Advisory Board and Committee. So I can't think of anyone better suited to moderate today's session. Helen, thank you for joining us today. Please take it away.
Thank you very much. And thank you very much to the organizers of the conference. This is an incredibly important topic. And I have the honor of just making a few opening remarks and then introducing our speakers. But I just want to acknowledge Tim, who just introduced me, because not only is he a complete stalwart in terms of his work in public health and global health. He's focused particularly, and I've worked with him closely on HIV and reproductive health over many years. But I think it's worth just saying that he also served in Bangkok as the director of the Thai Ministry of Health, US CDC collaboration for a number of years. So he also has a global experience as well. And he's also an advisor to many global organizations. So Tim, thank you very much for that introduction. So I just want to say a few words by way of introduction, building on what we've just heard from Tim. First of all, I think, in our lifetime, I think most of us always kind of heard about pandemics, and we heard about the 1919 pandemic of flu, but we probably never thought this was going to happen, that COVID was going to happen in our lifetime. Despite the fact that we'd seen MERS, we'd seen SARS, we'd seen Ebola, we'd seen zoonotic diseases jumping from animal species into human subjects very frequently. We still didn't think it was going to happen. And so although we were partially as a world prepared for this, in many ways, we weren't prepared for it. And what we've seen is this, what we'd always feared, this pathogen X, as we'd called it, did exactly what we feared a pandemic virus could do. It's caused massive morbidity and mortality, massive disruption. It's disrupted health services in a way we couldn't have anticipated. We've seen decreased immunization, increased maternal mortality, a lack of treatment being given for non-communicable diseases, for HIV, for TB, and we could go on. Massive health service disruption apart from what it's done in itself. But it's also affected economies, and we're going to feel that for many years to come. And one of the results has been hunger, and we'll be looking at nutrition as part of our discussion today. However, the one good thing, well, several good things have come, and one of them is an unprecedented global effort around scientific development, but also a real invigoration of the discussion about the need for global access. When you have a pandemic, it doesn't work, even if you're a rich country, just to be able to protect your own citizens, because the virus knows no boundaries. It's certainly, the virus likes aeroplanes. People will continue to travel. And unless we get global responses, which means that the very poorest and the very richest countries in the world need to have access to interventions, we will not get on top of this virus and this pandemic. And we've seen already breakthroughs, early breakthroughs in vaccines, many vaccines in the pipeline, and we've seen therapeutic breakthroughs with repurposing of drugs such as dexamethasone and steroids. But I think the one thing that we still have to grapple with is how do we make what we recognize as needed, access for the poorest countries, real? We've put in place something called the ACT Accelerator. Many of the global players, including WHO and donors and UNICEF and Gavi, have played a part in this. We put in place something called the ACT Accelerator, whose aim is to accelerate access to vaccines and therapeutics and diagnostics. And that is really trying to address access. We know that in the 2009 pandemic flu, that unfortunately the African region only got access to vaccines months after the pandemic had come and gone. So that cannot happen again. So in that context, we have a lineup of really interesting speakers. And let me introduce them all very briefly too. I'll introduce them now, and then we'll introduce them one after another to speak. So the first speaker is Panima Menon. She's a senior research fellow for the South African Asia Nutrition Programs in IFPRI's Poverty, Health and Nutrition Division. She also directs POSHAN, which is Partnerships and Opportunities to Strengthen and Harmonize Actions for Nutrition in India, which supports evidence-based interventions around nutrition. And she too has served on many international bodies in the field of nutrition. Our second speaker was going to be Dr. Mercy Mwangani from the Kenyan Ministry of Health. Unfortunately, she's been urgently called away, but we're delighted to have Dr. Nziza Liku, who is a technical advisor to Dr. Mwangani, and she is both an epidemiologist and public health expert, also working in the Kenyan Ministry of Health. Our third speaker, who will appear on video very briefly, and we're delighted to have that, is Dr. Supakit Sirilak. He is the Director General of the Department of Medical Sciences in the Thai Ministry of Health. And currently, he has guided Thailand's evidence-based response to the COVID-19 pandemic in his position as the Deputy Permanent Secretary of the Ministry of Public Health. Followed by Dr. Kanjanak Sirason, who is a project associate of the HITAP Foundation. She is a member of the Secretariat team for the Thailand Essential Medicines List, and she's working on many projects, including in response to the COVID-19 pandemic. So this is our lineup, and we'll go straight to the first speaker. And I'm delighted to introduce Dr. Nziza Liku, who will be talking to us about equitable access to COVID-19 vaccines and therapeutics. Dr. Liku.
Thank you very much, Dr. Rees, for that introduction. Receive my greetings from Dr. Mwangangi. She unfortunately could not be here, but she does send her greetings. And I will now be starting the presentation that she had prepared that I will be making on her behalf. And we'll just go through that right away. So the presentation that Dr. Mwangangi had prepared was on equitable access to COVID-19 vaccines and therapeutics. And that's what we're going to be speaking to today. And so I think, COVID-19 has been with us about at least officially 9 months in the country, that's Kenya. Our first case was announced on the 13th of March, and we've seen quite a number of disruptions, to our social and economic activity in that time. And worldwide, we are noting that scientists are working quite hard to ensure that we can have a vaccine. And hopefully by the first quarter of 2021, that should be available. And we have seen, Pfizer coming out to say that they are quite close to finding a vaccine. And the same thing with the Oxford, vaccine trial. We're keeping close tabs on that, I think, as a world. Everyone is looking forward to having those vaccines available. We do note that as we saw supply chain interruptions, especially with PPE for the frontline healthcare workers, was quite a challenge. And we do consider that that could be one of the interruptions that we see once the vaccines are actually ready to be distributed worldwide. And that is one of the things that we would like to keep in mind, even as we go forward with this discussion around how to ensure equitable access of vaccines around the world. And so the case for equitable vaccines, there are so many things that we can consider, and thinking through the fact that without a clear framework for allocating these vaccines across the world, then it's possible that some areas will actually be left out, meaning that we would have pockets where there's still the disease going on and developing, and that the cases would continue to increase, especially if we're not careful about how to distribute the vaccines. We do recognize that, depending on resources in different areas of the world, there might be shortages in certain other areas, and again, hoarding in certain other areas, just based on the vaccine accessibility. And these are some of the things we hope would be countered by an equitable access program. Similarly to that is thinking through price hikes. Of course, this vaccine will be demanded all across the world. Everyone will be waiting to get a dose of that. And yet we are also quite clear that initially the number of vaccines doses available may not be enough to cover everyone across the world at the same time. And for that reason, that we will need to be rational about how we actually put out those vaccines. We also recognize the fact that in case there is this kind of hoarding and shortages, that some countries may actually be slow to share their data based on what they have found as far as their research with the vaccine. And we note that if that was to happen, then it does mean that production and further development of the vaccines would actually be hampered, which then would be harmful to everyone and not just, the areas where the vaccine is not reaching. And all of this would then lead to a much longer pandemic than anyone would like to see. So we're hoping that even as we discuss equitable access to vaccines, then that would mean that we can ensure that everyone gets the vaccine as and when they need it, and we can actually bring this pandemic under control much sooner. So what are some of the other risks that we see on this part of the continent as when the vaccine does become available? We are clear that depending on who has taken part in the vaccine trial, some of the vaccines produced may actually not be appropriate for certain country contexts. And that is one of the things that we will need to think about. And I'm delighted to see the fact that there's many vaccines that are, almost coming to approval, meaning that there will be many different vaccines available for the different country contexts. And we hope that that means everyone can be taken care of in that sense. Additionally, we will need to be careful about which risk groups to target. Who are the people who are most at risk, and especially our frontline health workers? When we're thinking about the elderly, how can we ensure that we do target the appropriate risk groups when the vaccine becomes available? Secondly, what kind of vaccine schedule will be available? Do we expect to have 1 dose, 2 doses? And it will be important for us to think through that, even as we share out the vaccines across the world, to ensure that the vaccine scheduling is aligned to the country context and that can actually be delivered to the last mile for the people who need it. Finally, with low capacity to conduct vaccine trials, we do note that that could also hamper the introduction of a new vaccine. If we have not prepared properly in different country contexts, we see that this could also be one of the challenges or the risks that could hamper vaccine distribution when that is actually ready. So as a country, what are some of the things that we're thinking about as we consider how to distribute the vaccine once it becomes available? So we would urge, everyone else to also consider these issues: technical criteria for equitable distribution. Who should get the vaccine? What kind of risk groups do we see? And then there's also the need to counter market forces, being cognizant of the fact that the whole world is waiting for this vaccine. How do we take care of demand and supply issues around this time? This will also need collaboration. We hope that we can foster collaboration by governments to ensure that different countries are able to share resources. So whether that's pooled supply and supply chain utilization across different areas. For example, in the East African region, could we consider pooling our resources together to ensure that we can get our vaccines in a more economic manner? And then also the financing mechanism. Everything does have a cost to it. So we've also got to consider, how do we ensure that some of the countries that are in the low and middle income regions, how can they actually get access to these vaccines, even in this time when everyone is scrambling for the same resources? So one of the things that we've had about, and I know Helen did mention it, and we're really delighted to hear and to learn about it, is the access to COVID-19 tools, which which were put in place by WHO at the end of April 2020, quite soon after the pandemic was announced. And these are in place to foster collaboration across different countries, and Kenya is part of this, and we are using these within our country to ensure that we are able to ensure equitable access across the nation. What this COVID-19 access to COVID-19 tools Act for short does is bring together governments and scientists, philanthropists and global health organizations to kind of discuss and think through how different countries can actually access this. And the goal of this is to ensure that we can speed up development by sharing our research findings, as I had mentioned and alluded to earlier, by ensuring that we can pool production where possible, and that ensuring that we can have equitable access, across the different countries. One of the things that has been considered is bringing production and manufacturing a little closer to the countries where these vaccines will need to be, put in place. And the ACT Accelerator is organized in 4 pillars. And for this particular, presentation, we are definitely looking more at the one on vaccines and equitable vaccines. But we are quite clear that this would also be one of the pillars that we can use for health system strengthening. And COVAX, which is one of the ACT pillars, is an umbrella facility by Gavi that is intended to facilitate testing of vaccines and ensuring that we can have these in a timely manner at a lower cost for all of the people who would require it. And this is aimed at pooling demand of resources, as I have mentioned previously, especially with procurement, ensuring that we can have a global solution to this pandemic in a way that everyone is able to access the care they need at the time that they need. So from our government perspective in Kenya, what are the things that we're thinking through as we think about how to allocate this resource once it does become available? So as far as equity is concerned for us, these are the 5 areas that we are considering. We will want to think about risk groups who should get this vaccine based on how much risk they are under. So we're thinking through healthcare workers, the elderly, people with comorbid conditions before we have this vaccine accessed by other people within the country. We're also thinking through the vaccine schedule. Will that vaccine require 1 or 2 doses? Will there be a booster required? And based on that, what kind of delivery structures would we need to put in place? One of the vaccines I know that has been touted so far does require some very low temperatures of -70 degrees to keep it, active. How can we ensure that that vaccine does remain active even in the hard to reach areas? How can we take care of the delivery structures to ensure that when the vaccine arrives where it needs to be, it actually is still viable and can be kept that way for the period of time that it is required before people get it? And then, of course, we have to think about financial resourcing. COVID has also brought with it some economic downturn, which everyone has experienced. So the finances and resources, are quite limited. But how do we allocate these resources to ensure that we can actually obtain the number of vaccines that we require for the country? And finally, is governance structures. How can we ensure that as a government we are putting forward for the people that need it within the country, the vaccine, and ensuring that the risk groups that we have outlined initially are the ones who actually access this vaccine rather than anyone else before that. So those are some of the issues that we are thinking through as a country as we go on to consider equitable access. And I do thank you all for your time and attention and look forward to further conversation around this. Thank you.
Thank you very much. A very comprehensive country perspective, which many countries would echo with different, really helpful. Thank you very much indeed. We are going to have questions at the end, so we won't have them after each speaker. So I'd now like to move on to the next two presentations. The first part will be a video, and the second part will be a presentation. The video is from Dr. Supakit of the Ministry of Public Health in Thailand. And the presentation will be from Ms. Kanjanok, who is from HITAP in Thailand, as previously introduced. So we look forward to hearing both presentations. Thank you.
Hello, my name is Kanjanok Sirasan. I am from HITAP in Thailand. So today I'll be presenting on behalf of Dr. Supakit Sirilakt, and I will show his video on giving a brief introduction in dealing with the perspective through the policymaker lens, how to deal with COVID-19 in Thailand. So what are we going to be talking today? I'm just going to briefly touch on the policymakers' perspective on how we deal with COVID-19 in Thailand, and go through the guideline development process and thinking in the perspective of ethical principles during pandemic time, and how do we apply this into our context. So it's an honor for us to have Dr. Supakit Sirilakt. He is a Director General, Department of Medical Science, Ministry of Public Health, Thailand, to give a brief introduction on this.
Dear PMAC webinar attendees, it is an honor to be part of this esteemed platform and share with you my experience through the lens of a policymaker. My leadership role in the Ministry of Public Health has allowed me to lead the healthcare workforce, and I hope to offer my experience from Thailand perspective. As you may already know, COVID-19 has posed a threat to almost all nations globally, and Thailand is no exception. In fact, the first confirmed case outside China was reported in Thailand at the beginning of January 2020. It took a couple of weeks for us to recognize the deadly effect of the disease and implement strategic measures in order to contain the virus. The Thai government announced a state of emergency on March 26, 2020. We have formed a Ministry of Public Health Intelligence Unit, which I chair, to review the evidence in a timely manner and inform the policy response. Given the urgency of this situation, we have to adapt our approach to ensure that important policy questions are being addressed and informed by evidence. One concern that has been raised during the pandemic is about allocating critical care resources. If demand exceeds supply, how can everyone have equitable access to scarce resources? This is especially the case in low and middle income countries like Thailand, where resources are limited. We rely on an approach that was informed by evidence to balance the policy objectives, societal value, and public expectations. The question is not so much about scaling up the critical care resources, but rather about allocating these fairly, consistently, and are ethically acceptable to all patients regardless of their COVID-19 status. This is why determining criteria for prioritizing critical care resources are so important during a public health emergency. Ms. Kanchanok, one of the members of the research team, will talk to the process and share the lesson learned, which hopefully could be useful for you to apply to consider in your setting. Thanks to the commendable effort of the Thai authorities and healthcare personnel, we have not yet had to implement this guideline because the case number in Thailand is still low. However, if the difficult decision had to be made, we will now have this guideline to ensure that everyone had equitable access to critical care resources. Thank you everyone for joining the session. I hope everyone stays safe.
So as you can see, thanks to Dr. Supaket on his perspective, as you can see that the critical care resources include ventilators and ICU beds, or even negative pressures, chambers, and some PPE. So those can be scarce in some countries, and in Thailand it's no different. So when you look at the headline throughout the world, you can see that there been a headline over the healthcare personnel have to play a god roles on deciding who to stay on the critical care resources or who to be left out, and that is duty versus virtual, and that's put a lot of pressures on the healthcare professions. So that's how important that this guideline will help to elevate those pressures. In the normal time, we have the fundamental medical ethics principle, which everyone may already know: respect for autonomy, non-maleficence, beneficence, and justice. But during the outbreak, those are also applied, but we have to have additional principles that come into time when demand exceeds supply, and these are maximizing benefits and treat people equally, or promote and reward instrumental values, or give priority to the worst of. But what is the most appropriate principle to Thailand? That's why it's the beginning of this protocol developments. In Thailand, the Ministry of Public Health had then requested to develop a guideline for rationing scarce critical care resources during COVID-19 pandemic. And in a team of research, we have done an extensive rapid review on literature reviews. And because this is going to be the first guideline of its kind in Thailand or in similar setting, we have to look on the recommendation and guideline from throughout the world internationally, and then we also have to ask the interviews with the healthcare professional to see what are the current practice at the moment and what is the current trend and how they're practicing in the real life. And then we draft guideline, we put it through 2 rounds of stakeholder consultation. And these groups of stakeholder consultation found a really important base to our guideline, because they consist of experts and specialists from multi-background. There's members from religious group, there's members from medical lawyers, human rights member, even from doctors and experts in physicians. So those group of people come to form a consensus on how do we decide on the criteria when we prioritizing critical resources. And then we draft the final version. Then we put it through to Ministry of Public Health for the implementation and review process later on. So what are the key findings? For the ethical principle, what we have found to be the most appropriate for Thailand is maximizing societal benefits. And we thought that patients should be assessed using objective and measurable criteria for critical prognosis, and that the criteria should focus on immediate and short-term survival prospect. And the criteria that we propose that the healthcare professional should use at least 2 of the tools that we provided, and that if the first 2 tools are giving equal score, then we can use the third or the fourth tool for additional assessment. And those 4 tools are Charlson Comorbidity Index, sequential organ failure assessment, frailty assessment such as CFS, critical frailty scales, or cognitive impairment assessment. And you can see the flow here. When the patient got accepted to the hospital in the emergency unit, the patient will then get accepted to the hospital, and the attending physician will start the process by assess the patient, and then will request or ask consultation with the patient review committee. And these patient review committees consist of nurses, expert physicians, a member of public or figures, or even medical lawyers. They will come to assess the patients by using the prioritization criteria that we have provided. And that when they gathered and compare relative score, then they will send this consultation recommendation to the attending physician. And by law, Thai doctors or Thai attending physician have to make the final decision. So the attending physician will make a final decision based on their recommendation. And that the patient will be decided whether to stay on critical care treatment or to step down to receive palliative care settings. And then after that, all patients will then pull for reassessment, and that is using the same criteria. That's complete the loop of decision-making process. So what are the lessons learned from this process? We have learned that decision-making process have to be explicit. It has to align with the Thai registration or Thai law, and it has to be endorsed by the recognizing authority or body, like for example, the medical councils of Thailand. And it is a good foundation that we have multi-background stakeholders to give a consensus idea and a different perspective. Although we have politicals and instrumentals influence, and that have to be taken into account as well. But the key message is that the communication to public has to be clear, it has to be transparent because of the sensitivity of the contents. And we have to ensure that regular review of the guideline development is a must for any updates later on. So
just if you could wind up now, we're running out.
Okay.
Thank you.
Yeah, so what are the implications for the future? So for the Thailand, this guideline will guide our medical professionals in decision-making process. For the low middle income countries, that could share lessons on the guideline development process, and that could apply this knowledge for the COVID-19 vaccine management. Thank you very much. If you want to find out information, you can ask me or follow the link. Thank you.
Thank you very much. I mean, that was really excellent. And this issue of ethics really coming into how we think about these things has become a very dominant theme in access to services, but also, and in the chat, you'll see it, who's going to get the vaccine. It's coming out repeatedly in different themes. So we'll come back to that, I'm sure. We've got questions in the chat. I will go straight to our third speaker, Dr. Purnima Menon, who's the Senior Research Fellow at IFPRI in India, and she's going to talk about progress on nutrition in time of crisis. What must health systems do? Purnima.
So thank you so much for having me here today. I will share a few findings, a few insights from our work in India, but mostly I'll be speaking on behalf of a very large consortium of partners who have come together to try to preserve progress on nutrition in this tremendous crisis called the Standing Together for Nutrition Consortium, as well as a range of other research partners who over the last couple of years have been trying to assess and understand how we can get health systems to do more for nutrition. The first question to ask, of course, is that why would we care or worry about investing in nutrition? and particularly from the perspective of health systems. Over the last many years, a range of evidence has accumulated highlighting the importance of nutrition for a range of goals, including sort of nutrition as a basic human right, the impact of nutrition, of investing in early nutrition on intergenerational equity from some really long-range studies, as well as economic gains that come from investing in nutrition. But for those people who worry about health, I think the most important reminder is that nutrition contributes tremendously to the global burden of disease today. And even if we think just about some basics such as maternal and child mortality, nutrition or undernutrition contributes tremendously to the underlying, as an underlying cause of child mortality. Almost 45% of children who die in the world today would not die if they were not undernourished. So from that perspective, I think the imperative to invest in nutrition is particularly important. We've also learned tremendously about what does it take to deliver impact on nutrition. We know, again, this is work that has been done by a very large community of people over a long period of time. We know we need to reach the first 1,000 days of life, not just for impacts on early nutrition, but also for lifelong benefits. We know we need to embed high impact nutrition interventions in a range of different delivery systems, including health systems, that we need to engage client populations to create demand to use these interventions and services, and that we need to address underlying social determinants. But we've also learned that, again, over these years, that missed opportunities abound in health systems, even though these health systems are in fact the first to reach these critical 1,000 days. And we've also learned, unfortunately, that global movements to scale up nutrition interventions and those that are focused on achieving universal health coverage have not been connected in ways that help each other realize their full potential. So from all of these perspectives, I think we stand at a moment in time where we recognize what needs to happen in health systems, but we need to walk that way. And now we have, these are some examples, and then I'll just come to COVID in a second. So this is work that we've done and published. Actually, this was launched at the last PMAC in January earlier this year as part of a whole supplement of work done by colleagues on the Countdown to 2030 Collaborative, where we demonstrated that those bars that are in red in these graphs are the reach of health service delivery platforms. And the little bars next to them in blue are the ways in which nutrition interventions are reaching the same people reached by those health platforms. And this is, to me, just a prime example of the kind of missed opportunities that exist today for us to be able to address nutrition via health systems. If you have 80% of households or 80% of pregnant women being reached by 4 antenatal care visits, but only 40% of them being reached by the simple nutrition intervention of iron folic acid, which is embedded in these systems, you have a problem, right? So now what's happened with COVID-19, of course, is that the health systems themselves, the ones that deliver these health and these essential nutrition interventions and the platforms that reach communities in the first 1,000 days, they have been disrupted tremendously. But along with those disruptions, what we've also found is that there have been adaptations to try and sort of restore and preserve these kinds of services, and we're seeing that start to come back. So, for example, what happened in the context of India is we found that in antenatal care services, adaptations were made to deliver not in local centers, but in higher level facilities. We know that there were disruptions to growth monitoring, which now has come back on. But we also know that there have been a range of positive adaptations in program delivery. So what's interesting to me in the context of nutrition and health systems and COVID-19 is that along with the disruptions, we're also seeing a range of positive adaptations that may give us signals about how we can do even better once we move through the pandemic and through to the other end. Now, one of the things that has been done by the global nutrition community is to try and model the impacts of these disruptions in health system services, but couple that with the other factors that we know affect undernutrition. So, for example, a very impressive paper by Robertson et al. From Johns Hopkins showed that disruptions to the COVID-19 pandemic, not just on health services, but also on other factors affecting undernutrition, were going to have pretty dramatic impacts. These are modeled impacts on increases in maternal and child mortality, obviously an outcome that health systems care deeply about changing. So in the context of nutrition and health systems, I think what we are seeing is that we need the health systems to do more for nutrition, but we also need the health systems community to recognize that without preserving nutrition through investments in economic and social protection and other such programs, we are going to see impacts on the outcomes that the health community cares very deeply about, which is mortality, maternal and child mortality in particular. So I want to come back to saying, what are some examples of critical health systems opportunities that we really should not be missing for nutrition, given what I've shared with you about the tremendous links between nutrition and health outcomes, as well as the tremendous opportunities within the health system to address nutrition. So in pregnancy, for example, every contact should include interactions that include nutrition counseling, include weight gain monitoring, and include counseling and provision, if needed, of micronutrient supplements. Within preventive child health contacts, we need to think about ways to include counseling and support for infant feeding, particularly for breastfeeding. We need to include growth assessments, which in turn serve to help us understand whether children need to be referred to malnutrition treatment. And finally, in the context of curative child health contacts, again, we need to be looking at growth assessments, referral to malnutrition treatment, counseling on diet. And then last but not least, as I mentioned, nutrition and dietary factors are among the leading causes of death, even among populations worldwide, not just with mothers and babies. And so across all adult contacts, there should be a strong emphasis on screening for NCDs and dietary counseling. So, I think where we are is that, clearly there are tremendous disruptions that we are seeing, but it's also an opportunity and an impetus for us to think and rethink about what is it that we are bringing back and bringing forward in terms of not losing these opportunities. So to close, given the tremendous links, as I mentioned earlier, between nutrition and health goals, as well as the key opportunities within health systems to address nutrition, we're really calling for a movement to make sure that essential nutrition services within health systems don't take a back seat, even as health system services are restored and adapted in country after country as we move through the pandemic. Mothers and babies who are not reached today with essential nutrition services in the context of health systems is human capital lost, not just today, but for the future. Health systems are already reaching families in this critical life period for nutrition, but the service protocols, even those in the context of COVID-19, must continue to include actions to address nutrition so that those opportunity gaps are not exacerbated, and so that we learn how to strengthen that. And then last but not least, I think we're in a situation where both across health systems and in nutrition, we are still flying a little blind in that we don't fully understand the consequences of the pandemic in terms of disruptions to services, disruptions to coverage, and to impacts. And so we need a joint investment across the nutrition community and the health systems community on data systems to track service delivery, and also to ensure that these data systems actually also integrate nutrition indicators, not just health systems or health service coverage indicators. So let me stop there, and I'm happy to take questions as we move through the rest of the session. Thank you.
Thank you very much. Three and a video are really excellent presentations, really looking at sort of the many different challenges that this pandemic has thrown up. So we'll now open up and go into questions. And the first question, I'm jumping between the chat and the Q&A. So please, everyone who's watching, feel free to put your questions into the chat or into the Q&A, because I see people are using both. So the first question that I'm going to pose to Dr. Liku is about vaccines. This was one of the early questions that came in. And there are two questions, really. Here it is. This is great. We've got the questions transferred onto the slide if everyone looks. How will your country determine the priority populations for COVID-19 vaccination? There's another question that we'll also come to, which is about how will you define what is a healthcare worker in different settings where we will have a range of people offering health services. Dr. Liku, over to you.
Thank you very much for those questions. I think these are the questions that everyone will be grappling with, essentially. They are pertinent, and most of the people around the world, especially policymakers and health economists, are probably grappling with this, thinking through how are we going to decide who should get the vaccine and when they should get it. Some of the research we have seen, based on health economics and how to allocate health resources, and even some of the conversation going on around COVAX, is such that people will want to prioritize the people who are most likely to fall ill and who are in greatest danger, if we can say that, of catching COVID-19 and possibly dying from it. And in that sense, then the people we think about in our society would be first healthcare workers, because they do have constant exposure. The people in the hospitals taking care of us, the people in health centers, whether it's primary healthcare or in the hospitals, who are taking care of the critically ill patients. Those people are constantly coming into contact with the cases of COVID-19, and therefore their risk of exposure is quite high. So those are the people we're going to prioritize first, just because of their constant exposure. And in that group, we're also thinking about people who sometimes may be forgotten, such as emergency medical technicians. We're also thinking through the people who will be offering the vaccines. So sometimes those can be actually forgotten and left out, and you give the vaccine to every other healthcare worker but forget the person who's actually administering the vaccine. So that's number one. Secondly, we're thinking through the elderly, because COVID-19 is disproportionately affecting those who are older, and so we're thinking about protecting those people in our society, those who are elderly, ensuring that they can be protected. And then the third stage would be thinking through people who have comorbidities, someone who has a condition that does predispose them to a worse condition if they do get COVID-19, predisposing them to, severe disease. So the diabetes and the hypertension, those kind of people would be the next tier that we might consider. And then finally, after that, then we will think about the rest of the population. And so essentially, that is a conversation happening worldwide. Everyone's thinking through that, and we are following suit with everyone else. And then on to the second question on how we think about the healthcare workers. How do we decide who is a healthcare worker? So of course, starting with what we might call official, healthcare workers. So if that's within the health system structure, so who do we have in the health facility? Who have we got at the primary care level? Who have we got in, dispensaries and pharmacies? Those are the people that we would think about. Secondly, there's also the level of community healthcare workers. For us in Kenya, we are strongly utilizing our community healthcare workers, especially for contact tracing in this pandemic. So that's another group of healthcare workers that we will not be leaving out. And then I think from what the question was trying to ask, there's also thinking through the what we might call traditional healers, people who are outside of the healthcare system, the official healthcare system in that sense. And so those are some of the people that we would be considering, and part of the conversation around how do we distribute the vaccine would definitely take that into account, knowing that in our part of the world, that those are people who do offer healthcare, while it may not be in the mainstream way of it. Thank you.
Thank you. But I'm going to actually just extend that question to Ms. Kanchanok, because one of the questions that's also in the chat is, how do you prioritize? You're also an ethicist. There's an opportunity cost. If you're a self-financed for a vaccine, how do you prioritize I think we've just addressed that one. But the other question was about an opportunity cost. How do you prioritize buying a vaccine and the programmatic cost of a vaccine versus providing desperately needed curative services? Because the countries are going to have to make those hard decisions. Would you like to comment on that?
Yeah, so on this topic, I think it's coming into different perspective. Like if you think of the COVID distribution, the COVID vaccine distribution, and that in the coming year, and also at the same time with the current critical care resources, I think it like for critical care resources, it have to be treated and distributed urgently because people are in need for it, and that's to be thinking in a timely manner. But for the vaccine, COVID vaccine, that can be planned out. Like for example, people who can get access first, we have to look at also like so many other factors. Just to give it on that, I think it's gonna take a long journey for us to really consider and really plan out and how do we manage both of them at the same time. But at the same time, I think it's something that we've learned from the policy perspective is that the social vaccine is the most important things. People have to wear masks and washing their hands and keep social distancing. Whatever happens with the vaccine will be distributed 100% and people get all equitable access to vaccine, or at the same time people get all equitable access to critical care resources. They also have to consider that in mind as well. So I don't know whether that answer to your question, Helen.
I mean, it's a challenge. I mean, this isn't a perfect science. And perhaps before I come to Panima, because there's some questions that are coming up I wanted to ask you, but I want to ask both of you something, because having a list of priority people that you want to give a vaccine to, in terms of their risk profile, their risk of mortality and being ill, in a way, and then reciprocity for our healthcare workers. That's almost the easier bit. The more difficult bit is, to begin with, all the countries here that I'm looking at in terms of our panelists, we're going to have very limited amounts of vaccine. So say we only have 3%. And we have an epidemic that, in Thailand's done very well. I'm not sure what's exactly today, but Thailand's done very well. And Kenya's going up. So we've got two different epidemics and we've got a limited amount of vaccine. Is that going to change who you prioritize? So I'll take Dr. Kanchanok first, Ms. Kanchanok first, and then I'll take Nziza, because you were nodding vigorously. So let me comment first from a Thailand perspective, and then Nziza's thinking, and then I'm going to come on to some questions around the nutrition side. Please go ahead.
Yeah, so thanks to, as Dr. Supakit has mentioned in the video, thanks to all the efforts that the healthcare professionals in Thailand have done really well on contain the viruses. But I mean, like, that's definitely is the point. Like when we have the low number and people are thinking it's necessary to really, like, do we really need vaccine if we done so well? Like this gonna be so challenging in terms of how to manage the public's expectation as well. When the government has to also plan ahead that we have to have enough amount of vaccine in hand. At the same time, we also have manufacturers who have done some research in developing some vaccine in Thailand itself. So I think we have quite a well planned ahead in terms of what that we have tried to have enough vaccine for everyone. But definitely we will come up with the criteria. I think for HITAP itself, we have done some research on modeling who to prioritize on to get vaccine first. And it's actually in the research, it turned out that the healthy group, which is about the 20 to 30s age group, should be the one who get vaccine first, because that's the first group that will go out, hang out, and be socialized, and that we prone to the risk of getting infected. So I think in the same time, it's going to be different in each country. We can't use the same patterns, the same policies, or same rules to everyone in every country. So it have to be based on how we've done epidemiologists, or how do we perform as well. And also the public have to really understand that even though we have vaccine, do not exploit that, if you got vaccinated and you just go out there and live your life and do not wear masks, and that's not going to help, because we never know whether one dose is enough, that we could need like more than one dose, and that. So I think that's how we have to plan ahead. Yeah.
No, I think you're right. And Caesar.
Thank you, Helen, for the very difficult question. And I think that's one of the issues in public health, trying to allocate resources. How do you decide? Where do the ethics lie? Who should get it? I really like what Kanchanok has just, highlighted, that the younger population are the ones who are likely what they call the super spreaders. They are the ones that are having a hard time with social distancing and staying home. And, even as we begin to open the economy, because, we can't stay closed forever, those are the people who are in the workforce, going out daily, coming home. So yes, there has to be some consideration around perhaps thinking a little differently from what we have thought about traditionally. But as we're seeing in Kenya is we are definitely in our second wave of the pandemic. We are up to about 72,000 cases right around now, about 1,000 or so deaths, which, in the last couple of weeks has really risen after having a relatively, slow and quiet time. However, what we're also noticing is that a number of our healthcare workers are being, adversely affected. And so that kind of data is the kind of thing that's going to help us make this decision in terms of who do we actually allocate the resources to first. And, just like Kanchanok mentioned, what kind of evidence is out there as well that is showing that perhaps maybe you might want to think about the younger people before the older people, because, they are causing all of this, spread. So there is a lot of room, I would say, for taking in the research from different parts of the country, of the world. And I do like, this kind of conversation means that we get to hear about, the studies that are in different places and what they have found, and actually take that in, even as we consider our own, as we plan our own vaccine program, taking all of that into consideration. And perhaps, we may wind up with something very different from what has traditionally been thought to be the way to do it. Thank you.
Absolutely. And just to let people know that WHO, for example, is considering a sort of 3-by-3 table where you say, what state is your epidemic? Do you have no cases? Do you have clusters, or do you have community transmission? And how much vaccine have you got? 0 to 10%, 10 to 20% of your population, or 20 to 50%? Because it'll change your decision. All of those things will change your decision. And just one last comment on this is that, for example, some of the island states in the African region who depend on tourism are saying, if we get limited amounts of vaccine, we would want to give it to the people working in the tourism industry. Otherwise, our entire economy collapses. There are going to be so many considerations that we haven't yet thought of. Let me turn, Panima, to you. And I'm going to be a bit naughty because you mentioned the first 1,000 days, which is critical. Nutrition is part of that. But there's a very interesting question, which is really about school closure. And I know worldwide, one of the issues around school closure, and we saw the Man United football players saying this in the UK, that school closure also meant no free meals for children who are going hungry. So it's not only in the poorer countries where school closure also is tied. Could you just talk about school closure and what's your perspective? And if you did a risk benefit for things like nutrition and development versus COVID, where would you place and how would you evaluate that?
For a range of different reasons, all of which are centered around this issue of human capital, I think we are very, very concerned about school closure. So we are concerned about that both in rich and poor countries, because it turns out a lot of children depend on schools for their nutrition, but also a lot of parents depend on their children being in school to be able to engage with the workforce. And so the closures of schools is having sort of a range of impacts on nutrition, of course, on learning outcomes for children. It's having spillover effects on parental time, on gender. And I think, we're in a situation where what we are seeing at this point is, anecdotes coming out from around the world around how school closures are affecting, an entire ecosystem. From a nutrition perspective, particularly in regions like South Asia, another aspect of school closures that we're very concerned about is the possibility that it leads to school dropouts and early marriages, which, in turn has a whole range of other sort of lifelong negative implications, both for often it's for the girls who are married early and then for their children. So there's sort of, almost intergenerational potential negative impacts of, of the school closures. And so I think, the other thing that is emerging now from around the world is how countries have balanced and tried to address this issue of, what do you close to prevent transmission and, preserve, certain parts of society. So we are seeing countries where they closed certain parts of the economy but kept schools open, other countries where they closed schools but kept other parts of the economy open. And, I think we're only going to learn about the impacts of all of these kinds of policy decisions in coming years. My work is mostly on, low and middle income countries and focused predominantly on South Asia. And so, here I think we'll be watching really closely to see what happens in the next year or so with, with early marriages, but also nutritional levels, nutritional impacts, nutritional status, hunger among children. India runs the world's largest school meals program. There were a range of adaptations to that program across the different states. In India, similar to what happened in other countries as well, sort of home delivering either the meals or the ingredients that go into school meals. But we just don't know whether any of that, or we don't know how adequate that has been, because it's really something else to be, consuming your meals in school and attending class versus getting components of those meals home delivered. We're also sort of really flying blind at this point. There's a lot of speculation on these kinds of impacts and very little data, very, very little data on, how children are being affected, on how their nutritional status is being affected, on how learning outcomes are being affected. So those of us who work in the research community are also very concerned that, without sort of running data investments, a lot of countries, a lot of donors are making decisions that don't sort of bring together data on all of these possible consequences. So yeah, I think there's a range of different concerns there. And of course, the range of nutritional challenges is also fairly wide ranging, right? I saw that somebody asked a question about overweight, obesity, and snacking and mental health among children. Again, at this point, one has to speculate because there haven't been enough, data gathering exercises to help us understand what is going on to the diets of children when they're in their homes, what the consequences are for physical activity. We can only surmise at this point that things are not good. The closing of schools and then everything that's happening around it is another set of massive disruptions in the context of this pandemic.
Thank you. And I'm going to pick up one of the questions in the Q&A and tie it to that question. And Ziza, I'm going to put you on the spot. And it goes back to the school question, because it's asking, young people who get the vaccine first may not have symptoms, but can be the super spreaders. It really comes back to what is our view on the closure of schools. We've just heard from Panima about the nutrition and the developmental loss and the parental impact and the social impact. Do we open schools? Do we not open schools? How do we evaluate that at different stages of the epidemic? Ziza.
Thank you, Helen, for that. The experience in our own country has been such that we did initially, I think, just like everyone else, close schools. And then, of course, all these unintended effects, started to come out. Children were not, getting meals for those who are dependent on school meals. Children were then getting engaged in early economic activity, a bit of child labor, early marriage. And then, of course, there was the issue of just, social interaction. And that conversation did begin to come up. And what that did was, prompt the Ministry of Education to sit together with the Ministry of Health and think through what kind of measures do we need to put in place to ensure that we can safely open the schools. So that conversation has been ongoing, and we did partially reopen the schools, hoping and waiting to see, what kind of a response we would see. We were concerned as to whether that would cause a spike in the, in the cases and just the super spreader effect, as has been alluded to. So we didn't see much of that, and so for that reason, we are now planning come January to move on to opening, schools in full. Again, just in the background of, in the end, we do have to get back to normal. We do have to go back to life. And one of the things that we're keeping in mind is our public health measures. We are, quite concerned, of course, or cognizant of the fact that it does become difficult for children to, keep their social distancing while in school, sometimes keep a mask on all day long. So those are some of the concerns that we have, even as we, think through reopening the schools. But the time to do that actually has come. And then the other angle of it, or aspect of it, is ensuring that we've got, sanitation facilities up and running and ready in the schools. So increasing our hand washing facilities, ensuring that there's soap for that, ensuring that, children are getting guided and reminded to, constantly take care of those public health measures. So we do anticipate that we may, possibly see a bit of a spike as soon as we have more students coming back to school, and we are quite prepared for that. And I think one of the things that has not been taken off the table is, the possibility of reclosing if we see, some very unintended consequences. So that does remain one of the cards in our back pocket. We try so hard not to play it, because we do, we are eager to see society, get back to normal. However, as far as school closures go, we're looking forward to reopening, but, keeping in mind that we can always close in case we see some danger signs. Thank you.
So we've got no time left. We've got a few minutes left, literally 4 minutes. So I'm going to ask Panima, in 30 seconds, how would you prioritize? What would you say is the message to policymakers around the importance of nutrition in COVID?
I would just say don't forget about it. It has been often forgotten in the context of routine health systems work. It's too important to forget. Let's at least not have missed opportunities for those things that should have been there. And then, for the extras, we'll get to it later. But there are things that should be happening anyway. And so as health systems are being, re-examined in the context of COVID, please let's not forget nutrition, because it's going to affect human capital today, tomorrow, as well as lifelong disease in, 30, 40 years from now, if we miss the ball on early nutrition today. So that's all. Let's at least not miss those, things that are within reach.
Thank you. Kanjanok, 30 seconds. The importance of ethics in what we think about everything: treatment, vaccine distribution, etc.
The sense, the most important things that to do with ethics is that it's acceptable by the views of the public. So as long as it's transparent, that it's been met by their public expectation, and that's involved a lot of public opinions, that the member of social society had come together and to be able to decide what is the most appropriate principle for them. That's matter, because we can't apply others' principle to our context if our people didn't like it. So that's the base for it, and that we plan upon it. Yeah.
Excellent point. Thank you. And Nziza, in one sentence, you get now, what is your message about access to global policymakers who might be listening?
Thank you for that question. And access is I think the thing that we will be talking about for a long time to come as far as COVID-19 is concerned. And for us, we say we have to come together to ensure that everyone can get access. So more collaboration will mean that we can ensure access for everyone. Thank you.
Thank you. So with that, I'm just going to wind up. I mean, I think that you can see from this panel that many of the things each country is grappling with are very similar, but just very different contexts. But making priority decisions, building ethics, building leadership into those decisions, getting very important community trust in our decisions, because one of the reasons people have not adhered to some of the measures we've asked is because there's been little trust in what we're saying, and we've tended to change our minds from time to time. But incredibly important, but just to reinforce that this is a global issue, and it cannot be my country. This idea of nationalism solving the problem will not solve this problem. And hopefully the world will learn from this in terms of the SDGs, that we are better doing this together than we are separately. Now, with that, I'm so sorry we haven't got to all the questions, very important questions about refugees, displaced and priority populations. But the organizers have asked that you sign there's a little evaluation form that I think they're going to put up. It would be very helpful to get your feedback, because I do think that global dialogues like this are incredibly important to push the global discussion. And that has very much been picked up by groups like WHO, who have led the way in many of these aspects, but groups like Gavi and CEPI and many of the donor agencies. This has to be a global dialogue. So thank you very much to the organizers. And we would invite you to please complete the webinar evaluation. And to my three great women speakers, thank you very much indeed. And Tim, you're there in the background fielding the questions. Thank you very much for putting this session together. Thank you.